All right, so the recording has started. Everyone's present. We're going to talk today about wound care, dealing with modalities in wound care. So when I say wound care, what do you guys think of?
Burns.
Burns, okay, good. What else? You can type or you can say cuts, right?
Stitches, open wounds.
Yeah, any type of open wounds, traumas, right? Stitches, boo-boos, I like that. Pressure injury.
Cleaning and rebandaging.
Yeah, anything requiring bandaging, right? Pressure injuries are what I think of a lot. Unpleasant smells, exactly. When I think, just because of coming from inpatient, the number one thing I think of obviously is pressure injuries, just because it's so prevalent that you've got to make sure you prevent pressure injuries in the hospital setting, that they beat into you. Like the one wound you want to worry about is pressure injuries. But yeah, so anything, traumas, right? Gunshots, knives, anything to that effect is kind of what you're looking at when we're talking about wound care. So anytime that skin is open to something, even a burn is considered open skin, especially if it's killed off, right? But we can use modalities in conjunction with other therapies as well. Modalities can't be the only thing, right? You guys learned that already through this class. Is modalities are great, right? Just putting a hot pack on a person if they have a low back pain isn't going to fix their low back pain. But it can at least alleviate some of that low back pain so that you can go on to conjunctive therapy and actually strengthen their low back and allow them to get better. I'm going to turn up my cam light here just a little bit because I'm a little in the dark. That's a little better. So that's the key thing with, just like with everything else, we can do wound therapy with modalities, but modalities aren't going to be the only thing to get that wound better. And that's the important thing you need to know. This is in conjunction with normal wound therapy, which you guys will get in semester 5. So that's coming. The other group kind of got nauseated at some of the pictures yesterday, so I'm just going to warn you in advance. So in wound therapy, the main goals we're looking for is looking at how modalities can affect both at the cellular level, like, right, I said that before when we were talking about, I believe, we were talking about e-stim and that and ultrasound, how things happen at the cellular level, right? What can we do to trigger at the cellular level to help stop them getting into that chronic wound phase and get them back into a normal functional wound phase so that everything kind of heals back to normal, right? Now, let's say you've got a cut in your arm, right? And I've actually got one. If you got a cut in your arm, how should it heal? Should it heal from the bottom up? Should it close from the outsides in? How should it heal?
Is it inside out?
Outside in, I thought.
Yeah, it should close, right? It should come in together. It can heal the other way, but then it leaves a nasty scar, right? That's that healing of primary intention versus healing of secondary intention. I think you guys talked about that a little bit in pathology with Dr. Sokel, I heard, right? So when those wounds close, those edges have to approximate. If they get stuck in that wound phase and those wounds stay open, bad things can happen to the wound. And that's that chronic inflammation process that they get stuck in. We've got to return normal overall, I went forward too fast. Yeah, normal overall balance to that wound, right? What's the balance in our body called? Where we want the body, homeostasis, right? Not homeo doesn't play this, homeostasis. So what can we use? Well, heat and cold. And normally when we talked about wound care or talked about modalities before, one of the things we said was star contraindication, open wounds, right? And that's because in order to use heat and cold with wounds, you have to be specially trained in it. It's not like somebody's got a cut, you're just gonna slap a hot pack on it. You got to know when to use heat, when to use cold, and when is most appropriate to use each of those. Because if you don't, you can actually throw the wound into a vicious cycle where it ends up in that chronic inflammation cycle. So this is where it's really important, not to beat on techs a little bit, this would be one where I definitely don't want a tech doing any modality with a patient that's got a wound, because it's such a fine line that you walk with modalities to make sure that they don't end up in that chronic inflammation cycle. And then hydrotherapy, we talked about a little bit. We're going to go kind of through that. So cold, right? How many of you have ever had like a bloody nose or something like that and you put a cold pack on your face to stop the bleeding? Anyone ever do that? Yeah, right? Why do you use cold for bleeding? What does cold do? Vasoconstriction. Look at those technical terms. I'm so proud of you guys. Right, restricted blood flow. So the goal is to get those vessels to kind of close up. There's also some shows that there's some studies out there that show that it even helps with the clotting factor of our blood, that it helps it form that nice plug to stop the bleeding, right? But yeah, of course, we've done that. I mean, anyone that's got a kid has probably tried it at some point, because kids are notorious for getting bloody noses. It's just the way it is, especially in this area here with how dry it is. So we're going to try it. The main goal with cold and wound care is to control excessive inflammation. And you guys learned that in cold therapy, is that one of the main jobs of cold is slow down an inflammation cycle. Now, is inflammation needed to repair areas?
Yes.
Yeah, right. Or inflammation is part of that normal cycle. We want some inflammation. We just don't want that inflammation to kind of go crazy, right? We want it to have a party, but not a house party. We want it to be there just to kind of treat the wound and bring it into its phase, so it gets more into that proliferation phase and the remodeling and the maturation phases, right? But we need inflammation. You can't skip it, right? You can't build a house without putting down a foundation. Otherwise, the house is going to crumble, right? Same idea with wound care. You have to have the inflammation phase to have the base laid down so that you move on to the other phases. But some people just get stuck in that inflammation phase, and we got to be careful of that. Key thing here, though, also is cold does impair neutrophils, right? So if cold impairs neutrophils, that can be a problem, right? Because what's neutrophils' jobs? Have you guys talked about that in modalities yet? Not modalities, in patho?
Like white blood cells.
Your white blood cells, good, yep. They're kind of cleaners, right? You get your neutrophils and all your other kind of macrophages, or what I like to call them, the eaters of the dead, right? They're the ones that come in and clean everything up. So what are those cells called? What's the technical term for the cells that come in and clean up the area?
Phagocyte?
What's that?
Phagocyte?
Phagocytes, exactly, right? You know, I always, when I hear phagocytes, I think back to Michael Crichton in the book Eaters of the Dead. That's exactly what they do. They come in, they eat till they're full, and then they keep the nice gunk in there, and you get pus, and it gets out, right? You get a pimple on your face. That's basically, and especially when you get the whitehead on it, that's a bunch of white blood cells that have come to clean out any infection that was in that area, and they come in there and died, right? That's what those are. It can increase the incidence of wound infection if not done right. So this is why it's important with cold that you know what the parameters are for it. And it will affect the coagulation cascade, but it's worth the risk sometimes with certain patients, right? So that's the key thing here with cold. Why might I use cold in conjunction with wound therapy if the patient's got a lot of pain? Say they've got a really nasty open wound and they've got a ton of pain, and I have to do wound therapy on it. What could we use out of cold that could help it?
Numbing.
Yeah, the numbing effect, right? If I've got to go in and clean out a wound, and I can't even touch the patient because every time I get in there and I start cleaning out that wound, they're squirming and worming all over the place. It doesn't help me do effective wound care. But if I can numb the area for a little bit and get a little bit of a numbing effect, absolutely, right? And that's where it's kind of that real delicate balance when you're doing wound care. And PTAs can become specialized in wound care. It takes a good bit. I looked at it and I'm like, yeah, I'm okay. I could just treat wounds. I don't have to necessarily be specialized in them. It takes a lot to become specialized in a lot of the fields, but you know, it's amazing some of the stuff we can do with these therapies. And then heat, right? So let's think about if we have an acute injury, acute wound. Say, I've got like I said again, I got a nasty cut on my arm. I just did it. If I put heat on that, what's probably going to happen? What do you think?
It will bleed more?
It probably will bleed more, right? Because what's happening with heat? Heat does the opposite of cold. Instead of doing vasoconstriction, because vasodilation increases the blood flow. It makes sense. And it can inflame the wound more, right? Exactly. But by bringing that extra blood to the area, it's also increasing the blood supply. When we increase blood supply, we increase tissue oxygenation. We also increase the local area of, good materials in that area to increase the actual healing effect. So it brings all the good stuff to that area as well. in chronic wounds, right? A lot of times chronic wounds may end up stuck in that inflammation phase. And when they get stuck in the inflammation phase, they get oftentimes inflammation style swelling. That's not your normal swelling, right? We talked about this when we were doing aquatic therapy when we were in that whirlpool room. I talked a little bit about this, that, you know, your acute swelling is a lot more serous. It's a lot thinner. It's more like true water. Whereas when we get closer to that, the chronic phase of wound, what does that swelling fluid kind of look like? Do you remember? So the older the swelling, the kind of more gelatinous it becomes, the more gooey it becomes, right? So when you have swelling in a chronic wound, well, it may not be able to get out of that area, and so that area is going to become more inflamed. So we may have to use heat to kind of thin out that a little bit, alter the enzyme effect, right? There are some studies to show that it also stimulates fibroblast proliferation, right? So that means that if we're stimulating fibroblast proliferation, what phase of wound healing do you think we're probably in? What do you think? You remember the phases from patho? Yeah, it's sort of in the middle. Good, right in the middle. You're right. So that's that proliferation phase where everything's coming in and that meshwork is starting to get laid down to build that wound up, right? To repair it, to get it back to normal until we get to that remodeling and maturation phase. So we need those fibroblasts. Those fibroblasts come in and lay down our meshwork, and we need that in order to do it. It's also going to increase metabolism, right? You know this. If you're warmer, right, what do we have to do before we work out? We warm up. That increases your metabolism, gets you more likely to work out, right? I'm sure some of you have had that where you go to the gym and you roll straight out of bed, and you've got that kind of, and your workout. What's your workout like when you're that way? Yeah, not so great. Right? Or maybe you get warmed up and now you start going, but when you first get going, it doesn't work that well. Same idea with the body. We need to increase metabolism in order to increase healing. Accelerates proliferation of microvasculation and endothelial cells, right? So endothelial cells are what type of cells, guys? Yeah, skin, right? And all that tissue. So dermis, epidermis, all that fun stuff that you learn with Dr. Johnson, right? Heat does improve the phagocytic effect of inflammatory cells, right? So this is where we got to balance it, right? Because cold decreases overall phagocytic activity, whereas heat will increase it. But I'm sure that Dr. Suckles talked to you guys about this, that, you know, you want a certain amount of phagocytic activity to clean up the wound, but you don't want it to go out of control, because those eaters of the dead come in and they're not very specific. Right? They come in to remove whatever infection's there, and sometimes they'll mistake healthy tissue for infection, because especially if you got a viral infection, right? How does a virus affect us? Like right now, we've got the COVID virus going around. How is that different from a bacteria? Yeah, right? So it multiplies through, exactly, Era. It multiplies through your cells, right? So bacteria gets in us. The bacteria surround our cells and they lyse our cells and eat our cells. That's what a bacteria's job is, right? And if it lyses enough, it can, right, split apart and make more bacteria, and that's kind of how it grows. Viruses are a lot more challenging to treat. Now, we're finding that with COVID right now is viruses come in, and when if I get COVID right now, my form of COVID is different than if Dr. O'Neill gets COVID. Because the virus is going to get in me. Whoever gave it to me, it has a certain RNA substrate in it, right? It has a little bit of their genetic code in it, gets in me, finds my RNA, merges with me, and so now that's a different strain. So all of us carrying around, that's why when you get a flu shot, it may not always work 100% for everybody, because everyone's RNA and DNA is different. And so when those viruses get in us, they affect us a little differently, right? So that's kind of the way this works, right? Viruses act that way. So sometimes when those phagocytic cells come to the area, because those viruses have so manipulated our cells and look so much like our own cells, sometimes those phagocytes do eat a little too much, right? And it's not like there's some guy that's down there that's like, whoa, whoa, stop this eating competition. We're done, shut it down. No, they just kind of eat until they die. That's the way those blood cells work. So we have to be careful with that. Reduces complication with wound site infection after surgeries, right? We will use this occasionally with wound sites after surgery. A lot of times you'll find we do more cold after surgeries, and mainly because cold gives us a little bit more of that anesthesia effect, that pain relieving effect. But there are some surgeries where we will use heat. So hydrotherapy, now we're dealing with what? So we talked about heat, we talked about cold, now what we're talking about? Yeah, by multiplying itself through it, exactly. Water, right? Agua, good. Right? With water, water's necessary for life, right? So this is why we're like, well, can we use this in wound therapy? Of course we can. It's in our body, right? We're a huge bag of water. That's basically what our bodies are. So what kind of hydrotherapy, so what kind of water can we use to treat wounds? I talked a little bit about it when you guys were in that room with me. Right? What type of hydrotherapy can we use to treat wounds? You remember the modality we use? Remember we talked about whirlpool therapy, right? Yeah, whirlpool, exactly. And what we can use for whirlpool is we use that moving water to help mechanically debride a wound, right? So we'll talk a little bit more about that obviously in this semester, but debridement is where we come in and clean off stuff that doesn't need to be there, right? And as PTAs, do you guys know when you guys become PTA, and as me as a PTA, what's a type of debridement we're not allowed to do? There's one type of debridement we are definitely not allowed to do. We are verboten to do. Does anyone know? For those that may have been techs or may have worked in hospitals. Okay. It's Sharp's debridement, right? So Sharp's debridement is where we actually physically take out a scalpel, tweezers, right? And start cutting skin off of wounds. And we will do that. PTs do that.
Isn't that considered surgery though?
Not necessarily, no. It can be considered surgical debridement if they're in a surgery room, but Sharp's debridement, PTs do every day. They literally will go.
Oh yeah, I know that, but I thought they called it like surgery is why we can't do it. Like that's their form, their terminology.
Well, that's part of it. The other part of it is they say that in order to do Sharp's debridement, it requires constant evaluative criteria of the wound. So that means they constantly have to be evaluating, do I need to take this much tissue, or do I need to take this much tissue, or do I need to take this little tissue? And they say because of that constant evaluation that has to go on during that Sharp's debridement, that's beyond our scope of practice. I am okay with that. They can have Sharp's debridement. Honestly, if you ask most of the PTs that I know that do wound care, they're going to say, defer all debridement to the wound care prep. That's right. I'm okay as a PTA. I'm okay with PTs doing that. But I know some PTs are like, so you got some training in Sharp's debridement, right? I'm like, nope, that's your job. You guys got that. I'm okay. I have had training in Sharp's debridement because in Pennsylvania, it's funny. In Pennsylvania, we can do selective Sharp's debridement, but we can only do it with plastic tools. So we can have a plastic scalpel, plastic forceps. Yeah, plastic. The funny thing is, the plastic tools, yes, work. The plastic tools are just as sharp as the metal ones. I don't understand what the difference is between plastic and metal, but that was the way, and that was the PTs that said, if we can teach them to use plastic tools, we can unload some of our load and we can worry about the evals that are overloading us. So that was their way of getting around the APTA kind of saying, no Sharp's debridement. It's kind of silly. But yeah, so the debridement is where we take stuff off. And we will, right? So I have a couple pictures coming up with some nasty wounds. But if the wound has something like S-scar, does anyone know what S-scar is on a wound? So I'll spell it out for you. That's the way S-scar is spelled. Yeah, dead tissue. Yeah, it's black, dead tissue, right? It's different than a clot, right? So a clot is when we have the fibrinogen and everything coming together to seal over a wound. Clots can eventually develop into dead tissue on certain patients, but dead tissue is literally dead cells. And the more that S-scar sits on the wound, here's the thing that our body's kind of interesting, is when we get dead tissue sitting on healthy tissue, that dead tissue likes to spread. And so if we have a little localized area of dead tissue, that can spread, especially in stuff like the brain, the heart. Anytime you have any type of areas of dead tissue in those areas, they like to spread. And they'll kill off localized tissue until the body comes in and kind of seals them off and glials them off. So that's eschar has to come off, right? It has to get out of there. Any type of slough, right? So slough, and this is not to be confused with sloth, who's the guy that screamed, "Hey, you guys!" Right? This is slough. Slough is yellowy, mucousy, pussy substance. Right? Any of that that's in a wound has to come out. That's one of the first things we need to do when we're cleaning the wound is get rid of that. That's called devitalized tissue. If we don't get rid of it, we can't healthily vitalize the tissue and get good tissue growing in that area. So we have to get it out. Well, we can do Sharp's debridement. That's a really effective way of doing it. But if we don't have the ability to do that, we can do hydrotherapy and use a whirlpool and the force of the water moving around the area and the temperature of the water to kind of pull that gunk off of it. It's only going to remove loose material, which means if that eschar is bound down pretty hard, it's not going to come off, unfortunately, right? It'll also remove surface bacteria, right? Any unwanted foreign contaminants, anything like that. I think of a lot of times with what I've seen them with is burns, especially, where they'll put them in the large Hubbard tank, which a Hubbard tank is a really, really, really big, basically huge whirlpool, where they'll put them in, they'll circulate the water, and what the water does is it just takes all that dead necrotic tissue off the body. In the end, when you get the patient out, you've kind of got this muck in the whirlpool, is the best way to put it, because all that dead tissue is now in the water, and then you've got to clean the whirlpool. But it's really good for removing that dead tissue, and it's really kind of gentle, right? If I come at you with a scalpel and tweezers, you're going to look at me a little funny. You're like, I don't know if I want that. When we talk about doing whirlpool, it does similar things, and so it's a little bit more gentle on the patient. And they honestly, I tend to see that patients that get whirlpool therapy actually don't mind it as much as they really don't like whirlpool therapy. Yeah, so in all the dead tissue, exactly. Right, we'll just make a little bit of, primordial ooze out of it. It will also increase the rate of granulation tissue, right? What's granulation tissue? Have you guys talked about that in patho? Let's see, I'll give you a few seconds. So granulation tissue is healthy tissue, right? That's where if you've got a cut or you've got a wound and you look in the wound, it's that beefy red tissue. Right? And if you're one of those people that's the pickers, you see a scab, oh yes, pick. And you pick that off and you look under and you've got that tissue that kind of looks like hamburger, right? That nice, beefy, chunky red tissue. That's granulation tissue. That's what you want to think about when you're looking, you want to see that in wounds. You want it to look like nice, 85% beef, right? You want it nice and shiny and beautiful and pretty. That's granulation tissue. That means the wound's healing, right? Because you've got that flow of water, it does help increase the granulation tissue formation because that water will get a little bit of osmotically absorbed. And we know that our body needs water. It'll increase local circulation, decrease the wound inflammation. It does reduce pain. It's amazing how much, again, this patients really tolerate hydrotherapy. Usually, what we're gonna put is them in water of neutral temperature. Right, so 92 to 96.8, I think is the max we go. 96 is what the book says, just below body temperature. And we're gonna do it for 10 to 20 minutes. Gee, it almost looks like all of our modalities are 10 to 20 minutes, doesn't it? It just seems like this is a standard almost, one that you could almost use for board questions. I'm just saying. Yeah, we'll call it a whirlpool. We have to follow the problem with the whirlpool, and a lot of reason why a lot of clinics don't do whirlpool anymore is the protocols for cleaning afterwards, right? I talked a little bit about this when we were in a hydrotherapy lab. If we have a whirlpool treatment, first of all, the water has to be set up for the patient. The patient gets in, they create the primordial ooze after maybe it's their leg, they've got their leg in the water, and now that gunk's off the leg. Well, they pull their leg out. We've got to clean that now. So we got to get rid of that tissue, get rid of that water effectively and also safely. And then we've got to clean it out. So first of all, we have to wash the whirlpool out. After we wash the whirlpool out, we have to rinse the whirlpool. And then before we can use it with another person, we have to sterilize the whirlpool. Can't clean my bathtub. I can't even imagine a whirlpool. Exactly, right? Just imagine instead of soap scum, you've got skin scum. That's just kind of what we're talking about. So we've got to make sure that that's sterile for the next patient, because we've got to cut down that risk of cross-contamination. The other technique we can use hydrotherapy-wise is pulse lavage, right? Someone else's skin? Pulse lavage is fantastic. I like to think of pulse lavage as a super soaker with suction. Pulse lavage is a little water gun that you're going to put over the wound, and it's going to attach to suction on the wall. Usually in the hospital it's done. And that water is going to deliver a very, very powerful blast. Yep. That's fantastic. I don't know if you guys saw Dr. O'Neill's comment there that she had to clean the hover tank, and that was the end of her wound care. That's fantastic. And sadly, as a PTA, I don't have that option. They're going to be like, so who's going to clean? Oh, it's a PTA. My wound care experience started coming right out of school. My very, very first day at my very, very first PTA job, I was working on a weekend, and one of the therapists that was in charge in the hospital was like, so does anyone know how to do pulse lavage? And I went, I did it on an apple in school. And he's like, congratulations, you're the weekend wound care therapist. Okay. Yeah, whatever. I like wound care because I don't have to move patients as much. But pulse lavage is fun. Like I said, it's a super soaker with suction. So you're going to blast water into the wound area. And as that water blasts in, it's going to do a very high pressure kind of pressure wash of the wound. And it breaks up the slough and breaks up some of that eschar. And then it sucks it right back up into the whirlpool or the gun, so that it can be stored in a container and gotten rid of. It's really cool when it works. E-stim. So we've done all kinds of E-stims, right? We've talked about before, let's see, what are some of the E-stims we've talked about? My brain's drawing a blank right now. What are some of the E-stims we've talked about, guys? TENS, good. IFC, Russian. Exactly. So those ones we've dealt with so far. We haven't talked a lot about something like high volt or any of those like that, or direct current. We talked a little bit about it, but not as much about that, because PTAs, if you're going to use those, you're a little bit better trained in those when you get there. But we found that E-stim, cool, thank you, Dr. Neal. E-stim we can use to help speed along the healing of a wound. It's strongly correlated. Right now, we've got to remember with any type of research, correlation does not equal causation, but there's some strong correlation that if we use E-stim, we have successful wound outcomes. And that's good, right? But you have to be careful. There's a famous study that they did in New York City where what they found out was ice cream sales increase, murders increase. So therefore, ice cream causes murder, right? Does that make sense? I mean, if ice cream sales increase, ice cream, exactly, and murders increase, then they have to be linked. No, correlation doesn't equal causation. When do you think ice cream sales increase in New York City? Summertime, right? And when there's summertime, guess what happens to people? They're more outside. Right? And some people get a little more cranky when it's summer. One of them, right? And so the correlation doesn't always equal causation with it, right? But we do know that electrical stim does help influence those cells, and specifically at the endothelial level, to reorganize and help re-epithelialize the area. Mainly for me, the angiogenesis effect, the new growth of new blood cells and new blood vessels, is kind of the most important for E-stim. So it helps cellular migration, meaning bringing more cells to help increase the actual growth. Stimulates inflammatory cells, degranulation, so it helps calm down those inflammatory cells. It releases chemical mediators, right, such as growth factors and chemoattractants. And there's some studies that show it decreases some of those chemical mediators that allow for allergic reactions, your means, your histamines, your leukotrienes, all those. It does induce inflammatory cell proliferation, so we have to be careful when we're going through it and making sure that we don't push them too far with E-stim into inflammation. It'll speed the resolution of inflammatory phase, right? So it'll help us get faster through that inflammation phase. And again, the quicker we can move through that initial inflammation phase, I'm sitting a little too low there. The quicker we can go through the initial inflammation phase, the quicker we can get into proliferation. And proliferation is the repair phase. So if we can get through that as fast as possible and get into proliferation, everything kind of heals down. We can use it for edema. It'll improve collagen synthesis and the deposit of all the necessary cellular matrixing. Again, we're going to come in and lay down a nice little matrix, right? We're going to basically lay down a framework like you would for a house, right? You're going to put the rebar down, and that's where you're going to lay the concrete over it. Same idea with wound care. It's got to come in and lay that matrix down so that your collagen can come in and reorganize and recreate the skin that's been damaged. It'll start with the cell differentiation. What's differentiation mean? That's a big word. I don't like big words. What's differentiation? Because this is big right now in the medical field, right? You guys hear of stem cells before? What are stem cells? Does anyone know? Wow, this is a good day. Everyone's awake. Yes, very good, Jara. Exactly, right? There's cells that can become anything. Where do we find a lot of our stem cells at? Where are most of them stored at? Okay, baby cord blood. Yep, we don't carry that around with us too much anymore, but yeah, it is the baby cord. Yeah, the fetal cord is definitely there. It's produced in our long bones, right? Where at in the long bones? Marrow, good, right? Exactly. So those cells are created there, right? And they help our overall body, but they come out, they have to be differentiated, right? The last thing we want is to have a wound here in my arm and for those cells that come in to grow to change into bone, right? We want those stem cells to come in, become new epithelial cells, and reorganize in the layers of the dermis and epidermis like they're supposed to, right? I wouldn't want my dermis to be on the outside of my skin. I want my dermis on the inside. I want that epidermis over it. So the differentiation's when the body says, you're going to be, you're going to be a nerve cell. You're going to be a dermis cell. You're going to be an epidermal cell. And so the body differentiates those and puts them in the order they should be in, right? It helps activate that differentiation. Angiogenesis, again, another fancy term for just new blood vessel growth, right? Angio meaning typically arterial or red cell genesis, new growth, right? A new life. Eastin can have bactericidal effects, meaning it can kill bacteria. Now notice it doesn't have necessary virucidal effects, right? So it doesn't necessarily always work against viruses. But bacteria, Eastin does work against, because if you put enough stimulation in that cell, it can cause it to lyse. What does lyse mean? Lyse spelled like that. Not lice spelled like that. Those are two different things. Yeah, destroy or break the cell up, right? L-Y-S-E, cell destroy, right? L-I-C-E makes you itch. So don't get those confused, right? So lyse it. So we can use Eastin to kind of pop those cells and get apoptosis to effect. Can also increase circulation, produce neuromuscular contraction, right? Which Eastin we talked about so far that does neuromuscular contractions? Which one causes us to go, Russian, exactly, right? In Soviet Russia, Eastin moves you. So this is kind of some of the stuff. I just added this morning, so I'll get this to Dr. O'Neill because I found this great picture and I wanted to add it. So I'll get her to get the updated one of this. I just literally added this morning at about, I think, 3 o'clock. So when we have a wound, right, we use Eastin for it. In the inflammation phase, it's going to help increase blood flow. I thought this chart was fantastic. I don't know if you guys can see this, or I hope you can see this, but I think this chart is great because it kind of tells you what Eastin can be used for, right? In that inflammation phase, it'll increase blood flow, increase tissue oxygenation, and obviously this is English because it's oedema, but it can decrease edema and it'll increase antibacterial effect. When we move into that rebuilding phase, the start of the proliferation phase, it can increase membrane transport, allowing stuff to cross across the membrane. It can increase collagen matrix organization, wound contraction, so the wound can start closing. And it stimulates the overall synthesis of new cells in that area. And then when we get to the remodeling phase, when we're starting to close off that wound and get to that scar formation, you can increase epidermal cell reproduction and fibroblaст stimulation. So e-stim can do some pretty good stuff. So the most common technique for treating wounds with e-stim uses monopolar setup. Oh God, monopolar. That would be like one pole, right? So what does monopolar mean? Does that mean we have differentiated red and black leads or not? Remember, because I talked about it, somebody had asked, well, do I put the black here? Do I put the red here? And I said, well, with most of our e-stim that we do, right? Yeah, with most of our e-stim, so when we do TENS, when we do IFC, and even when we do Russian, the old Russian I talked about had a monopolar setup where one pole was active while one pole wasn't. Well, the new Russian, we don't necessarily do that. But for this, it is. So monopolar means we're going to have one active pad and one dispersive pad. And depending upon what we're doing with the wound will depend upon which one we're going to put where, right? And the dispersive pad is just kind of to draw the energy towards while the other one is pushing energy in. We're going to put that electrode right over the wound bed and sometimes in the wound bed. I love this picture. This is not an actual buttocks. This is a wound care model. So don't think they're getting embarrassed here, right? So where's my little annotate? There we go, drawing. So what we're gonna do is, first of all, we have to pack in that wound bed, right? Because you can see packing here. That packing's job is to fill that wound bed up, and usually we're gonna fill it with saturated gauze. So wet gauze. Why do you think we're gonna use water with regards to this?
Keep it from drying out.
Keep from drying out, number one, yep.
Better at conducting?
Yeah, better at conducting. If we just have dry cloth there and we slap that electrode on, the cloth's gonna act as an insulator, right? So we need a damp underlayer so that when we use it, it's kind of like the gel for ultrasound, right? If we just put that ultrasound head on the skin, we might get some sound conduction, but a lot of it's gonna be bounced up and cause crystal damage. We need that ultrasound gel in order to allow that energy to get delivered. Same idea here. If we just put the pad on that wound, not much is going to happen. Not much is going to happen. So we need that e-stim or that water to help conduct it. And so then we're going to put that electroconductive gauze, which is what I was talking about there. And so here we see this person is packing it in, and they're using, what are these things called? What's the medical term for them?
Forceps?
Forceps, right? Which is the fancy term for what?
Tongs.
Tweezers or tongs, exactly. Right? But we have forceps in medicine. We don't use tweezers. Now, understand, a lot of states, we're not able to do that. We can't use the tweezers. So that means if we're going to be packing the wounds, guess what we're going to be used in pack the wounds?
Your hands.
Hands, exactly, right? They're going to get these hands. All right. Clean electrodes placed over the wound, packing secured in place with tape. So there we got everything nice and stuck. Now, hopefully if we're going to do wound care, we do a little bit better job of taping it than that. I'm assuming that was just for picture's sake, but man, we could have done better with the drawing, right? And then we're going to put the dispersive pad, right? So the dispersive pad's a secondary pad, and that's going to draw the electricity to it. So in this case, over to the left here, right? So over here, one of these pads is going to be active, and one of these is going to be inactive. Right, let me change the color. So we'll just say here that the red is our active pad and that purple is the inactive pad. What's going to happen is whatever voltage this red is driving is going to go that way. Because what do we know about opposites in electricity? They attract, right? Exactly. So if I've got a positive pole over here and a negative pole over here, the electricity is going to follow from positive to negative. And so that's going to help push it, especially in the case of like edema, right? Edema we know has a charge. So what I can do is if I know the charge of edema, I can put that like charge on the area that has edema because likes repel. And I can put that opposite charge closer to the core of the body. So, and then what it'll do is this will push the edema up towards the opposite side that are getting attracted to. Same idea here. The electrode is going to be placed, right? And then we're going to drive electricity into it. And it's going to stimulate the body to act the way it should act. It's actually pretty cool that it works this way. How fast am I going here? Oh, it is 9:15. Okay, so I'm going a little bit here. So a lot of times we use high volt, right? So remember, I talked a little bit about, and we talked a little bit about this in physics. Voltage isn't necessarily the most important thing. Every time somebody hears voltage, they get a little concerned. I'm going to adjust my camera here just a little bit because I keep constantly going too low. Voltage isn't what necessarily kills us. What is it that kills us as far as electricity goes? Do you remember? Not voltage, current, right? Good, right? So current is measured in amps, from André Ampere, right? So when you see high volt, you don't think, oh my God, I'm going to shock these patients to death, right? It's the current that's important. So it's going to use a high voltage, but kind of a low current flow. High volt's not the most comfortable at e-stim. I'm going to admit that right off the bat, right? I love this. It uses a twin-peaked monophasic waveform composed of 2 pulses every very short duration and relatively high amplitude, right? So what it's doing, it's delivering a charge, boom, and then it shuts down. And it delivers a charge, boom, and it shuts down. And by delivering those pulses, right, this is all really fancy stuff at the bottom here that I'm going to do my favorite part for this down here. F, Y, I. Because if you ask any PTA in the field, we don't remember this part of pulse duration. I'd be willing to bet that even Dr. O'Neill doesn't remember all of that down there, other than looking at it maybe in the book. But what it's going to do is going to deliver these 2 charges, boom, deliver the electricity, calm down. It's kind of like Russian in that way, right? Because Russian delivers the current and then shuts off for a period of time, and delivers the current and shuts it off at the time. Well, it depends. So, Eric, it depends on what my goal is. That's a good question. I should have probably covered. Let me go back here real quick. So, Eric asked, do we place the wound, the electrode over the wound, or we place it side by side? Depends on what we're doing. I got pictures for both just because the original picture that was in this was all kind of busted up. So if we place it over it, it's going to drive the current into the wound and really stimulate the fibroblast cell migration. So it's really going to stimulate the wound growth. These out here are more to stimulate the wound closure. So I wanted you to see kind of both of it. The one they're usually on either side of it, the goal is to get those sides to approximate and kind of close shut, right? If I put e-stim on your butt like this, I guarantee that wound's going to close shut. I'm just saying. The charge under the active pad is the one that's responsible for its physiological effects. That's the major thing we need to know, right? So here's the fancy technical terms of it, right? Beneficial results can be obtained regardless of stimulus parameters using the 300 to 500, right, microcoulombs of electrical charge delivered, meaning it's not delivering a lot of electricity to the patient. That's the main thing you need to know about that. Treatment schedules vary, right, to as little as 1 to 4 hour treatments given 3 to 4 hours a week. So this is not a short e-stim. And most of the time, this is going to be put on as unattended e-stim, meaning we're going to set them up, we're going to set the machine up, we're going to set the time up, and we're going to let them on that e-stim. Because if I have to sit there for an hour, so how's that e-stim feeling? Great. Okay. How about now? You're going to run out of things to talk about with the patient in an hour, right? So most of the time, we're going to come in, we're going to treat the wound, we're going to clean the wound out, put the e-stim on, leave it on for about an hour or so, and come back in an hour, right? Maybe come back a half hour, check on the patient, come back in an hour, take the e-stim off, and then we're going to redress the wound. There is some sort of a threshold, and this is one of the things that research is looking into right now. There's a threshold of exposure time after which continued e-stim does not produce added benefits. We found this with ultrasound, right? You know, when you get up into the 12 to 16 concurrent treatments of ultrasound with an injury, most of the times they've hit this threshold where ultrasound is no longer beneficial. Same thing with e-stim. The only problem with e-stim is it tends to be based upon the person's physiology, right? So if you're a healthier person that has, you know, a lower fat to muscle ratio, and you have just a general healthier diet, you seem to see benefit longer from e-stim than if you have a high adipose value, right? And then we learned about that before, that with adipose is actually what to electricity? Is adipose a conductor, or is it not a conductor? It's the opposite. What's the opposite of conductor? Yeah, blocker, right? Not conductor, deflector, we're getting close. Insulator. Remember that? There we go, yeah. So it doesn't allow that electricity to get in as much. That's why there's a lot of studies that say that that's probably why somebody's got a higher adipose value may not get the most benefit out of an e-stim treatment. Now, the good news is if they have a wound, most of that adipose is out of our way. Just saying. It is, especially if the wound's bad enough and we're doing e-stim with it. Most of that, we get a nice open cavity, put that e-stim in, right? But that will fill back in with normal tissue again. So that can, as they get more and more treatment, it's going to become less and less effective, right? This is just like any other treatment, right? So patients, and you'll find this when you're in the clinic, patients get a lot of effect out of e-stim and hot packs and ultrasounds early on in their treatment, right? And then it's not doing so much for them. It's more of a placebo effect for them, right? It always drove me nuts when I was in the outpatient clinic and the person comes in and is like, yeah, I don't know if I can handle therapy today, but I'm definitely here for my hot pack. Really? 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 Hot pack's not going to do anything at that point, right? They've reached that kind of stimulus threshold where hot pack's just kind of the placebo and it makes them feel better. That's about it. Same thing here. You're going to hit a point of diminishing returns where you get a lot of return, and then that curve's going to flatten off. And you're not going to get as much out of the e-stim. Now, the good news is most of the times the studies haven't shown that you'll eventually get I'm drawing a blank here, a detrimental effect from e-stim. It just won't get as much of an effect out of it. So that's good. So if you go too far, not like it's going to hurt them. Here's that what Eric was asking about, the two equally sized electrodes placed on either side of the wound, right? Delivering a simultaneous asymmetrical biphasic current, right? So biphasic meaning up and down current, right? So what does a biphasic wave look like? You guys remember that from talking about e-stim? That's not a straight line. Clear that out. Need my straight line here. So if this is our kind of straight line of zero current, right? Biphasic current looks like this, where you got a high, a low, high, low. So it's going both positive and negative. Do you remember that a little bit? Maybe? Petit peu? Okay. Right, so the biphasic allows for both those waveforms to kind of come in and hit the area. And that'll help approximate those wound edges, which is nice. And the other part about this one is the electrodes don't necessarily have to go down in to the wound itself. I'm kind of sad that they did this, but these electrodes have definitely seen better days, just saying. So we've done e-stim. Well, the next thing we can do is ultrasound, right? And ultrasound, so what type of a modality is ultrasound? You remember? How does ultrasound work? It says it in the name. You can have a thermal effect, right? Yeah, it's sound waves, right? I always think back to Transformers. It's sound wave. Okay, maybe it's just from my growing up. I don't know. Anyway, so what's the specific way that ultrasound? What's that really fancy term for the way that ultrasound produces sound waves? Do you remember that? Where it uses electricity and a crystal. Do you remember the term for that? Starts with a P. Piezoelectric, good. Piezoelectric is when you use piezo, no, just kidding. Piezoelectric, excellent, right? Piezoelectric. This is where Mr. McKeever gets tested, see if he can spell piezo. Right, piezoelectric. Fancy term for electricity being converted into sound by a crystal, right? So maybe those people that use those fancy crystals to treat everything is, no, that's not true. Anyway, so it's a little different wavelength, just saying. So those crystals inside receive an electrical signal, the crystal starts vibrating, and that sends that sound wave down into the wound, right? It's through that cavitation, right? Mars is in retrograde, thank gosh. Exactly. I'm so happy for that. I don't know what that means. I'm just going to go with it. I really hate when Mars is not in retrograde. So that sound wave goes through and it causes cavitation, a series of compressions and rarefactions, right? You remember that from physics, where the sound waves are compressed and then there's space behind them where the rarefactions. Causes little air bubbles to occur. Those air bubbles work at that cellular and subcellular level, increase your localized, what are those little cells that bring energy, that use energy in our body? The mighty mitochondria. Yeah, the mighty mitochondria. And when they get stimulated up, good things happen. And that's kind of the way it works. Well, with ultrasound, we can use ultrasound to stimulate the tissue in the wound, right? It'll stimulate those inflammation cells. And what says degranulation, it means it stops them from eating as much. So if we are in that chronic inflammation phase, we can use ultrasound to stop that chronic inflammation a little bit. So it stops those macrophages and mast cells from eating as much. And it'll also help stimulate the fibroblasts, which lay down that matrix again, to proliferate and creating a greater number of fibroblasts in the localized area. That produces more collagen, that lays down more basement membrane, and that lays down an overall better wound bed. And you get more of that granulation tissue. Can reactivate the healing process by stimulating natural debridement process. So in the case of somebody having some of that eschar on there, we can actually use ultrasound a little bit on that eschar, and the sound going down into it will kind of cause the body to say, hey, this tissue's dead, let's let it go, right? And then we'll just let it go, let it go. Be one with the wind and rain. Oh, wait, no. So to let, this is the way my brain works, guys. So it kind of lets go of that and allow the body to naturally debride those wounds that actually, stuff that's in the wound that doesn't need to be there. Cytokines, right? What are cytokines? Do you remember? Have you guys learned what cytokines are? Or what all your ions are? Because often you hear them when you hear somebody talking about something like claritin. Claritin talks about that. White blood cells, right? They're inflammation mediators, right? So say you go outside right now, and it's starting to get that way outside right now, where stuff's starting to bloom, right? We're starting to get a little bit of, outside is the place we're not allowed to be right now, by the way. Where stuff is starting to bloom outside, and that pollen count starts picking up, right? As that pollen count starts picking up, some of us will get affected by our cytokines, right? Our histamines and all that, and get allergies. And we'll get stuffed up and we'll get all snotty and it'll feel great, right? Exactly. The enes are our mediators of inflammation. When you're getting stuffed up in your nose, that is inflammation in your nose. That's all it is, right? The body's saying, I need to fill my nose up so that stuff doesn't get down into my lungs. Because when you get that stuff down in your lungs, what goes along with it? Cough, right? Because then it gets caught in the cilia going down your lungs, and so you want to try to keep it out. So your body's trying to protect any of that stuff, that foreign objects, from getting down in and causing any type of infection. That's the histamine and the cytokine effect of the actual inflammation. If you look at some of your antihistamines and all those, if you look at Claritin, you look at, what are some of the other ones? Allegra, on all the nasal sprays, all those stuff. They all work on specific chemical mediators of inflammation. Not all of them work for each of the mediators. Well, cytokines are kind of those that help kick up that inflammation, right? So we may have to kick that inflammation up in order to get through that inflammation phase faster, and ultrasound can help with that. We can use it to alter scar tissue, right? That in conjunction with other types of scar therapy as well, right? We want scar tissue to be nice and pliable. We want it to be as close to original tissue as possible. But when you have scar tissue in that area, it's one of the things you kind of have to understand. We'll talk about this more again in wound care, right? When you get scar tissue, the scar tissue is only about 80% as viable as your regular tissue, right? It's only about as 80% as elastic. You remember what elastic means from physics? When we hear elastic, what do we think of? Stretchy. Right, so we always think stretchy, but really what elastic means is the ability to stretch and then return to its original shape, right? So if you get a cut on your arm and you get a scar there, if you have a perfect scar that is laid down as similar to the original skin as it was, it's only going to be about 80% as functional as it previously was. in that elasticity portion, right? So that means what happens if you cut that area again? Is that area more likely to cause damage in the future? Just say yes. Thank you. Just making sure you guys are still awake, right? So yeah, so if I get the ultrasound can help lay that scar tissue down and make sure that scar tissue gets back to as normal as possible, right? So you don't end up with a nasty scar like I have in my neck. That's not a functional scar, right? That's actually bound down to my platysma underneath. Especially right at that point where we get that scar formation going, ultrasound can be really useful for making a mature, normal scar. We just talked about promoting release of chemical mediators from the inflammation phase, right? Those cytokines, those histamines, all that activate the fibroblasts. So here's what we're going to do. So ultrasound, when we deal with ultrasound in the wound area, we're going to use sterile hydrogel, right? And usually we use the same stuff we fill wounds with, which is just this clear, like ultrasound jelly. We're going to fill that wound up, and then we're going to lay transparent sheet dressing is what it says here. A transparent hydrogel sheet dressing. Really what we're going to get most of the time is a tegaderm sheet. And I'm sure you've seen tegaderm sheets in the hospital. When you get an IV site in, they lay that clear plastic over it so they can see it, but they keep everything from getting into that site where you've got a wound. That's a tegaderm sheet. We're going to lay that over so that we don't put the ultrasound head down in the wound bed. Because let's just think about it. If we lay that ultrasound head down the wound bed and we're digging around in that wound bed and then we take that ultrasound head out, even if we clean it perfectly, there's still going to be residual tissue there. Yeah, gross, exactly. Right? So just think about it like somebody sees you do an ultrasound on the wound bed and you're looking over at the guy that's got to get ultrasound on his calf. You're like, I'll be right over there with this. Just hold on a few minutes. Oh, that's gross. So we use that tegaderm sheet to allow it. The other thing we may do is bladder technique. Right? I think we talked briefly about bladder technique with ultrasound, where we're going to create a fluid bladder to help transmit the sound down as well. And we can also do immersion technique. If I've got a patient that's got a wound on the heel, I can put their foot underwater and do ultrasound on it underwater. And that allows some hydrotherapy effect to go along as well as the ultrasound effect. And so we're going to sit there and do normal ultrasound. Now, if we want to get a healing effect for ultrasound, what parameter are we going to adjust? Do you remember what parameter we adjust to get a healing effect for an ultrasound? Right, we go to pulsed. Good. What's that parameter called though? So we have pulsed and continuous. That is the duty cycle. I said duty. Right, so that's the duty cycle. So pulse, again, we're going to do somewhere, most times we do wound care, it's 20%, but that's not a hardcore number. So don't quote me 100% on that. Get it? It's 20%, don't quote me 100%. I'm so funny. But we're going to do a pulsed ultrasound over the area. So that means the head's going to be on and off at whatever rate that pulsed is, right? So if I do a 20% ultrasound, right, that means that ultrasound head's only going to be on 20% of the time and off for 80% of the time. So it's going to deliver a refracting pattern that's actually driving those cavitation waves a little bit to help with healing. You can do it on the peri-wound tissue as well. So this is going to be ultrasound just on kind of the normal tissue on the outside. When you hear peri-wound, what does peri-wound mean? What's the, for medical term, around? Yes, right? Peri meaning around. If you have the perimeter of an object, talking about the area around it. And we can even do this with the wound being packed and actually being filled already, right? Or we can use ultrasound. These are kind of the standards here. Again, I said 20% is usually what we use, and look, the magical number right there is 20%. And why are we only going to do 3 megahertz? Why do we only do 3 megahertz with wound care? What do you think? So our choices are 3 or 1. 3 is used for what? Yeah, right. We're doing superficial, right? We don't need to penetrate down to the bone, right? And honestly, if we penetrate down to the bone, it's going to be uncomfortable because they're going to get unstable cavitation. So we just want to get that superficial layer, and that's why also we'll do that 20%, right? Laser. My question is, when you use laser, what do you do with the sharks? I just don't understand what to do with the sharks with lasers. No? Sharks with freaking laser beams? Okay, fine. I didn't even get a laugh out of anybody. I was hoping for a laugh. So laser, when we think laser, we think like cartoony type lasers that blast things and would explode. This is a little different. This is low level laser therapy, right? So it's not burning lasers. This is lasers that actually cause energy and causes that natural kick up of those chemical mediators and everything. A lot of studies show that lasers found profound physiological effects on tissue healing. So profound means what? What is profound? If I am giving you a profound lecture right now, no clue. Yes, great. It has a lot of effect, right? An amazing effect, a ton of effect on it, right? So they've shown that laser right now has some really cool effects on wound care. And the good news is the research is definitely coming out about this now. It shows I'm a big, you'll find with me, I am a huge proponent of LLT, low-level laser therapy. I love it. I love it in not only wound care, but I also love it in just regular treatments. I've had some great results from it, and you know, I'm still 50-50 if it's, you know, a placebo effect or if it actually is working with the patient, because I talk laser up a lot when I'm at the outpatient clinic, and it seems like every time I talk it up, I have a great effect out of it. You know, the body does amazing things when they think it's going to do amazing things, right? So the studies are showing that now, depending upon the laser wavelength we use, the energy density, the power density, the frequency, and the treatment schedule, we can really have a really amazing effect on wounds based upon what we do with laser. And I really am excited about this. All of this are what we found by research can occur because of laser. We have protein synthesis, which means everything's laying down a little better. Cell growth and differentiation improves. The cell proliferation, the increase in the cells in the area, improves. Cell motility. What does motility mean? Didn't know you were getting a English lesson while we're teaching, did you? Movement, right? Exactly. The ability for cells to move around and lay down properly. Cell degranulation of the old phagocytic cells is really big. The activation of DNA synthesis, right? So where the body actually starts taking those stem cells and kind of differentiating them, it gets better. The change in membrane permeability to stimulate nerve depolarization, to help influx of extracellular stores of calcium. So it allows you to steal some of that calcium from the surrounding area to help lay down some of that new bone growth and the new cell growth in that area. It's really amazing the way this works. The downside is with laser, and it's been downside in outpatient therapy right now, a lot of times we don't get paid for laser. And it's because the research just hasn't affected Medicare enough to say, okay, this is a valid modality. And Medicare is very, very careful about what they approve modality-wise, right? We used to get paid in Medicare for cold packs and hot packs, but we don't anymore. Why do you think we don't get paid for cold packs and hot packs anymore? They don't have a good idea why? Yeah, people can do them at home, right? It's not a skilled therapy, they don't consider. Now, I would counter that I think it's a very skilled therapy because people are likely to burn themselves or get frostbite themselves, right? But the other thing they saw is that a lot of clinics were just throwing a cold pack and a hot pack on the patient to get, guess what? One more billable unit. And they said, well, that's cool and all, but nah, we're gonna cut that out. So they're really careful with what they approve for modalities, right? They want to make sure that, first of all, if they're going to approve this modality for this treatment, that modality has clinically based evidence in improving it. And they're really starting to open up to laser in wound care. A lot of the wound care therapists or wound care specialists like Dr. O'Neill was talking about, a lot of them are starting to carry around a level 3 laser to do in conjunction with it and are actually getting good results out of it. But Medicare is kind of what drives all our other insurance, right? So if Medicare says this is good, Blue Cross Blue Shield will say it's good. So will Cigna, so will Aetna, United Healthcare, all those. But right now, Medicare still says on laser, we're not so sold on it yet, so we can't get reimbursed for it. And that's the downside of lasers. Right now, if we do it, we don't get a lot of reimbursement. So we just talked about all this stuff. The good thing with laser that I found, especially in that acute care phase, is this one down here, is I found that it stimulates a phagocytic activity so that it'll actually help clean up anything that's in it. We did a study back in Pennsylvania when I was back at WellSpan, which is a big conglomerate in southern Pennsylvania. We did a study on the effects of low-level laser therapy post-op day 1, day 2, day 3 on total knee replacements and total hip replacements. And what we found is we had a lower infection rate when the patient got 2 laser therapies a day. And to this day, at the hospital that I worked at, they still, every patient that comes in and gets a total knee replacement, a total hip replacement, they will get therapy twice a day and they'll get laser twice a day with therapy. Because if we can reduce that overall infection rate, why wouldn't we? Right? Because if a patient gets infected in that wound, what's going to happen? They're going to have to come back in for more surgery. So it definitely has to do with that stimulating that phagocytic effect down there. Increased collagen deposition, which means that scar becomes more normal. So this is kind of the application we do here. So the laser tips apply perpendicularly to the wound with skin covered by a transparent film. Again, most time we're just going to use that standard tegaderm dressing, which I'll show you guys when we get to 5th semester. Procedures carried out for a specific period of time depending upon the energy level and light level delivered, right? Usually short treatment times. This is what's neat about laser. In a wound size like this here, right? So let me get my annotation here. A wound about this big, the full laser treatment probably is only going to be about 60 seconds. It's really quick. And that's another downside to it as far as, therapy goes, because for that short period of time, we're not going to get a full unit out of it. So it's not like we can lengthen that laser time. That doesn't work that way. We can't say, well, let's just do extra. There's that kind of diminishing return curve, right? We get good return, then kind of flattens off and we don't get as much. So it's not like we do extra laser, they get extra better. There's a nice defined curve with laser. Most of the units that come with laser have settings in them for wound care. I know there's one clinic in town that has, one of the clinics I used to work at, they use laser quite exclusively because it works with their patients. And they've gotten great results out of it, both for wound care and just treatment in general. UV light. Where do we see UV light at? Where do you get UV? Yeah, the sun, right? The sun delivers our UV light, and that can give us either our tan, or you can look like me and be milky white, whichever you want. The sun's our major source of UV light, right? We found that ultraviolet C is a really, really good resource for actually helping with keeping bacteria counts down. I have to see if I can find the article I just read the other day about it. They have this new unit that they can roll into a hospital room. It's basically this little robot, and the little robot's like a Roomba, and it goes around the room, and on top of it, it has this rotating UVC light. And that UVC light has been shown to kill almost all the bacteria in the room, including MRSA. What's MRSA? Does anyone know what MRSA? What's that?
Isn't it a hospital, like the superbug created by hospitals, and it's really hard to kill?
Yeah, so I would say it's more created by doctors giving too much antibiotics more than just hospitals itself, because hospitals aren't totally to blame for it. It's more the fact that when I was growing up, and probably when Dr. O'Neill was just getting around to being a kid, because she's a little younger than me, when we went to the doctor, it didn't matter what you had. You came in with a cold, they gave you penicillin. You came in with, a knee injury, they gave you penicillin. Here, have some Cillin, have some Cillin, have some Cillin. And my docs, particularly that I went to, I can remember growing up as a kid, I can't tell you how many penicillin tablets I took. Yeah, exactly, Emily, thank you for agreeing with me. My doc actually had the big jug of penicillin in his office because his wife was a pharmacist, and they would dispense the penicillin as you were walking out. It's just hilarious. But because we did that and gave penicillin for so much stuff, we created these superbugs, right? And there's a lot of signs that maybe even this COVID stuff is a super virus because of using antivirals so much. But that's another topic entirely. But yeah, MRSA is methicillin-resistant staphylococcal aureus, right? So you don't have to, I think you have to know that for patho. You don't have to necessarily know that for this class. But it basically means methicillin-resistant. The Cillins are our main treatment. Penicillin, ampicillin, all those are our main treatment to treat staph infections. If they become methicillin resistant, now we can't use those psyllins to treat the staph infection, which means it can become more prevalent. And if it gets into your blood, you can get septic. They found is UVC kills it. So even a small dosage of a patient that's got a wound and we hit a little bit of UVC on the area, especially if they are MRSA positive. And how do we know if somebody's MRSA positive? How can we find that out? Those of you that are going to ever go inpatient, they're going to go and you're going to find when you go into the inpatient world, you're going to find you start loving your yellow gowns, because when they come into the hospital now, they're swabbing everyone's nose. Now, when they swab the nose, they can test that and get a pretty quick test back if the patient is MRSA positive. If they're MRSA positive, they're going to be put on contact restrictions.
I heard somewhere that almost all hospital employees eventually become MRSA positive. Is that true?
I would say it's pretty, I mean, Dr. O'Neill can probably even chime in on that. I pretty much concur. Most of the nurses I see that come in for hospitals after they've been in the field for long enough, most of them are MRSA positive. Now, here's the deal. If you have MRSA on your skin, it's not really a big deal, right? I could have MRSA on my skin and not know anything, because staph is a natural occurring flora and fauna on our body, right? Staph actually helps us protect us from other bugs. When it becomes a problem is when you end up with an open wound like these patients that we're talking about with wound care. Because at that point, staph says, well, look, at this skin is nice, but that wound looks tasty. And it'll start invading the area. And then it'll become an invader versus just being a protector. So that's why we use ultraviolet C. We found that, hey, if somebody comes in with a MRSA, well, why don't we take and try this and see if we can kill it off at the wound area? I don't quote me on this, but I'm predicting eventually we might even be given a UVC treatment to most patients that come in the ER if they can tolerate it, to try to help keep some of that MRSA down and keep it out of the hospital. Because right now that can be bad. You know, you having MRSA may not be a problem, but if it gets in a patient's wound, that can be a problem, right? That's why we go on these standard precautions we have right before we go into the patient room. What do we have to do? We have to foam in, we have to wash, we have to glove up. That's, as much as we like to think that's to protect us, it's not. It's to protect the patient from anything that we might be carrying, right? That's important. Also, UVC is shown to help epithelial migration. There's some studies out there that have shown UVC also is really good for treating acne. And that makes sense because acne is typically a bacterial infection in the skin somewhere. So if it helps kill bacteria, well, that kind of makes sense. It would work good. Now there's a level of it, right? Just like all other UV lights, there's only so much of it you want before you have that detrimental effect from UV as well. And UVC is one of the lower levels, so it's the 180 to 250 nanometers. So it's not as likely to cause cancer as some of the others like UVB and UVA. They can filter the wavelengths a lot safer than UVA, UVB, which I just talked about, which reduces the risk of skin burns. That's important. We don't want to treat the wound area and burn the skin around it. My brain just, where was I going with? I don't know. My brain just totally skipped off track there for a second. Sorry about that. Squirrel. A lot of times when we do the UVC treatment, we may not actually use any type of dressing on it. And the nice part about it is we don't have to, because we don't have to go direct skin contact with UVC treatments. For me, I always thought it was funny because I've got one of those Sonicare toothbrushes, and the Sonicare toothbrush I have has a little UV container that you can put your toothbrush head in and close it and activate it, and it supposedly kills all the bugs. It's even starting to get out into the commercial markets now for killing bugs on stuff. They make have any of you seen the phone sanitizer thing yet? Do any of you have that? I don't know where mine is, or I'd show you it. There's this little chamber that you can get that you put your phone down in and close it, and it allows UVC rays to kind of flood the cell phone, and it kills any bugs that are on your phone. Not like physical bugs, but any type of bacteria on your phone. So here we go with applying the tongue depressor to the periwounds area, right? We'll coat with a layer of petroleum jelly, and then treatments are either anywhere from a few minutes to an hour, depending upon what we're trying to kill and how long we're trying to kill it, right? So there's dressing. Why do you think we're putting that draping around the outside of the area of skin? What do you think the goal is? Thank you, Jaira. We're trying to limit exposure, right? Even though we know that UVC, well, privacy too, yeah, it's probably good. The other thing is we know that UVC is not as harmful as UVA and UVB. It's still ultraviolet radiation. And we know that radiation, when it enters our body, has a tendency to cause problems with our cells. So we're going to try to limit that exposure to the area and try to keep it mainly to the wound. That's the goal. So we only kill the stuff in the wound. And like I said, that staph that's on our skin may be helpful for keeping other bugs out of that wound eventually. Here's a small portable UV lamp, delivers wavelength of 254 nanometers, held perpendicular angle from about 1 inch from the wound, and it just energizes it. They can use it daily until signs of the wound infection are gone. One of our previous instructors, Dr. Kelly, when he and I first came to the Valley, actually came about the same time I did. He's a CWS, Certified Wound Care Specialist, and we worked at the same place. We used UVC treatments a lot on patients that had infections. You know, those are the wounds that you open up and you're like, oh yeah, that's infected. Because wounds that have infections have a very, very specific smell to them. And this is one of those smells you're going to learn. It's kind of like C. diff. You learn the smell of C. diff and you'll never forget the smell of C. diff. You learn the smell of gangrene, you never forget the smell of gangrene. The smell of an infected wound, when you open it up, it becomes very obvious to you when you've done it for a while. It's the worst. Which one? C. diff? C. diff's a great smell. I don't know what you're talking about.
Yeah. C. diff. I remember when I worked in the hospital, one side of like IMC would have one side of the unit would have a C. diff patient, but it was the worst when the other side C. diff patient, and it was like there was no breath of fresh air anywhere in that.
They're competing in the room. That's right.
Ugh.
That's why I always carried a little bottle of BioFreeze or Vicks with me when I was Dr. O'Neill said there's even a decent mask. The smell is unforgettable.
Yeah,
right?
You'll never forget it.
Nope. Yeah, an infected wound's the same way. When you first smell an infected wound, it'll stick with you, and you'll know then when you open up those wounds. I'm not supposed to be touching my face. I just can't stop, evidently. You know how they tell you not to do it, and now you just can't stop it. Yeah, exactly. That was where that's hilarious that you're going that way. If you ever see a nurse that's putting coffee grounds in a room, that's the scary room. That's usually means they're trying to use the coffee grounds to overpower the smell of C. diff. And it does work for a while, but then that odoriferous emanation just penetrates everywhere. And usually it's around the room too. You walk up to the room, you're like, yep, that's a C. diff room. They usually get precaution signs up too, but it's funny. But same thing with a wound. When you open that wound up and it's infected, I'll never forget the first time I experienced gas gangrene. I was doing some charity work down in Haiti with one of the docs from Pennsylvania. And we had this guy come in, and I was helping him doing some wound care while he was doing the other stuff. And what you'll find is when you do a lot of, if you guys are interested in doing charity work, you'll do a lot of stuff that you don't do here because you're as close to a doctor as they may get to see for years. So I was helping him a lot with his surgeries and everything like that. This guy comes up and he has his foot all wrapped in these huge peppermint leaves. And the doc's like, well, what's wrong? So he starts peeling back those peppermint leaves. And as soon as those peppermint leaves got far enough back, that was the first smell I've ever had of gangrene. And I'm like, I will never forget that to this day. It's a beautiful smell. And his toes were like just dangling there too, but that was beside the point. So yes, so the smell you'll remember. So when we see that smell, we can actually help by doing wound care and treating it, especially with UVC, to help try to kill down some of that infection. Pneumatic compression. We talked about pneumatic compression. We showed a little bit of pneumatic compression, didn't we? What did you guys see pneumatically compressing? What device? You borrowed them from UNLV. The Game Ready, yeah, right? What does pneumatic mean? Because the two types of compressions you often see are hydraulic compression and pneumatic compression. We don't do hydraulic compression with patients very often. Hydraulic meaning fluid, pneumatic meaning, anyone know? If you have air, yeah, right? So if you have most of your cars that you have, most of your vehicles have pneumatic shocks, air compression shocks, right? They keep your car as you drive down the road, it keeps it nice and smooth. So you can use pneumatic compression, specifically intermittent pneumatic compression, in conjunction with all your other therapies to help remove excessive edema, right? if we can reduce that venous congestion, stop that kind of block up in that area, we can actually use it in conjunction, like it says down here. So this is just like everything else, in conjunction with compressive stockings, right? So specifically TET hose in the hospital. Just because we're doing pneumatic compression with the patient doesn't mean they don't have to wear their compression stockings. That is going to be in conjunction with it. So we're going to put those compression wraps on. It's going to squeeze and kind of force that flow up and out of their leg. And then we have to put their stockings on to keep that flow from returning to the area, specifically with patients that have diabetic ulcers, venous stasis, arterial ulcers. If that area gets swollen, there's nowhere for all that bad gunk to get out. So that's just going to sit there and it's going to become static, and bacterial static areas become more infected. So we want to force that edema out, that swelling out, so that the normal venous return happens and we can get all that gunk out, filtered through our kidneys, and get it passed. If the patient is going to be swelling, so this is a key thing, anytime that you have swelling, that limb needs to be elevated, right? Elevated above the what? If possible. Heart, good. We'll apply the appropriate compression sleeves. And we usually, with pneumatic compression, and I think I mentioned this a couple of you that asked about the Game Ready unit. Usually pneumatic compression, they're going to stay under 80 millimeters of mercury. Why do you think it's going to stay under 80 millimeters of mercury? You probably learned about this in anatomy. Good, right? What's that? Which part of BP? Yeah, the resting blood pressure. Good, exactly. See how these classes kind of combine? Usually it's 40 to 60 millimeters, so it does stay a little bit under that, but definitely under 80 is what we want for these compressions. We'll usually do 90 seconds on, 30 seconds off. And that allows that compression to come up. It pushes the fluid out. And hopefully, as long as we've cleared the upper trunks, because if we haven't cleared the upper trunks, we're not going to be able to do anything. That's a totally different topic. It'll go back to the heart, and then it'll relax. The blood will be able to return with fresh new arterial blood, and then it'll squeeze again and kind of force some of that swelling out, and then it'll relax. And usually for this, it's about a 30-minute treatment. So that means we're going to put them on this pneumatic compression, and they're going to be on it for a little while. This is where you tell the patient, get comfortable. You're going to be on this a little bit, and watch some Judge Judy, or, I don't know what other stuff's on TV. You can watch anything you want on the coronavirus right now. But it may last 1 to 4 hours, depending how bad they are, especially if you're working in the women's health field. Women's health, they'll do a lot of pneumatic compression for a long period of time, just to make sure they get that swelling out, but it is in conjunction with everything else. So there's a lot of literature that shows that e-stim and everything can help wound care closure. We talked about that, right? But again, just like anything else, all of this has to be in conjunction with regular therapy. Even doing wound care like I would do in the hospital, just doing wound care is not going to be everything, right? Dr. O'Neill doesn't like wound care, right? But if I go in and clean the wound, I'm hoping somebody's going to come after me and get the patient up and moving, because we need to return normal blood flow as well. So they need to get these units, right? These good treatments, but also in conjunction with getting moving. We know that if a patient is stagnant, bad things are going to happen, right? The more stagnant we are as people, the more sedentary we are as people, the worse our health is. Our bodies are made to move. There was just a study I was reading yesterday about COVID that shows that a patient that gets therapy as soon as they come in the hospital is more likely to get better with COVID because they're moving, right? It's a predatory virus based on our sedentary lifestyle. The more we sit and let it collect in our lungs, the worse we're going to get. So definitely need respiratory therapy. They need a little bit of up and moving. Same thing here. We get ultrasound, we get e-stim, we get pneumatic compression. It's not going to be any good unless we actually get them up and moving afterwards, right? A lot of promising studies on UVC, right? Hydrotherapies, effective in reducing inflammation, and superficial heat's really good for wound drainage. So we know all of this at this point. There's a lot of research out there for us. And again, we've got case reports. So I don't know how much you guys have talked about research yet. I know Dr. Vreskin hits research pretty hard in her class. But case reports are kind of our lowest form of research, right? Did you guys learn that yet? If I'm doing a case report, how many patients am I checking out in the research? usually? A case report. It's a hint. 1, yeah, right? A case study or a case report, we're only looking at one patient. So there's a lot of studies that show case reports for laser therapy. We need proper randomized clinical control trials, right? I'm going to pick a little bit right now just as an example on the current society with use of hydroxychloroquine for treating COVID. The study that came out was only about 25 people. Out of those 25 people, 15 of them left the study halfway through the study. And so we have 10 people that we have generalized research on, but it wasn't a randomized control trial. The doctors knew who got the medication. The patients knew who got the medication, who got the placebo treatment. So it wasn't a really good study to show effect on COVID, right, with hydroxychloroquine. We just don't have a really good study. There are studies going on right now. We don't have a really good study on it. Same idea here with laser. There's a lot of individual studies out there that show individual patients got good results out of it, but we're all different. So if we don't have a conclusive group randomized control trial, we can't specifically say that's why Medicare doesn't pay for laser. It's not a really big study yet, and there's a lot of meta-analysis coming out now, which will help probably allow laser to get paid for in the future. But we definitely need more studies on laser. Yeah. Exactly, Dr. O'Neill. And even when you look at that, the side effects of hydroxychloroquine by far, to me, at least coming from a pharmacology background, are far worse than what I would even possibly worry about getting benefit out of. The side effects in the heart are just atrocious. It has some really, really bad effects on the heart. That's why a lot of patients that have lupus that take it end up having heart problems in the long run. But yeah, so when we're looking at choosing a modality, we have to look at the wound and taking care of what we use, right? The main thing when we do wound care and we do modalities in wound care, we have to see what our hospital has, right? It doesn't do me any good if I want to do ultrasound on a wound if I don't have an ultrasound unit. I have to have the equipment, right? And then I have to kind of look at what I want to do. Like eSIM has cellular actions that benefit pretty much all phases of repair. Ultrasound stimulates inflammation phase, right? UVC, infection and highly colonized wounds. Hydrotherapy helps remove tissue. So that what this is saying literally is not all modalities should be used with every type of wound, right? Each therapy has its own specific treatment for wounds that could be effective for some, but not effective for others. This is a control study here that talked about different ways of using therapy. I'm not going to read it. And then I am done. Are there any questions I can answer about using modalities in conjunction with wound therapy? I'm going to escape and stop the screen share. Bring myself back to center. It was a lot of info, yeah. And again, we're going to get a lot more into wound care when we talk about it in 5th semester. They just had their first 2 of 3 classes on wound care that we're doing, in 5th semester. Does anyone have any questions I can answer? Anything that you might have question on? Seems like everyone's quiet. Is everyone still awake? Just checking. All right. Well, that's it for me. You're goofy. I know you're a goof. There you go. So Dr. O'Neill says use the rest of the class time to review for chapter 12 and 14 and quiz on Monday. Then I'm going to stop the recording here so that